Bismillahirrahmanirrahim. Today we are going to discuss primary myelofibrosis. Now these are three most important entities in chronic myeloproliferative disorders. Chronic myeloid leukemia, polycythemia vera, we have discussed. Now this third one, this we will discuss today, primary myelofibrosis. The hallmark of primary myelofibrosis is the development of obliterative marrow fibrosis, which reduces bone marrow hematopoiesis and leads to cytopenias and extensive extramedullary hematopoiesis. This means that in this disease there is too much fibrosis of the bone marrow. What will be the result of this fibrosis? Normal hematopoiesis will be disturbed. This will be reduced within the bone marrow. So due to this reduction in hematopoiesis, this will result to cytopenias in the peripheral artery. This means hemoglobin, TLC, platelet count may be low in the peripheral blood. And as a compensatory mechanism, there is extensive extramedullary hematopoiesis. In any conditions we have discussed, these organs which were producing hematopoietic elements in the intrauterine life, the spleen, liver and lymph nodes. So in any increased demand or in unusual conditions, again this hematopoiesis can start in these organs. Now this is known as extramedullary hematopoiesis. Hematopoiesis out of the bone marrow. Histologically, the appearance is identical to the spent phase of chronic myeloproliferative disorders. JAK2 mutations are present in 50 to 60% of the cases. In pathogenesis, we can discuss this. JAK2 mutations we also see in most cases of polycythemia vera, maybe 95% of the cases, but here 50 to 60% of the cases JAK2 mutations are present. Most of the remaining cases have other mutations which also are hypothesized to stimulate the increased JAK-STAT signaling. So whatever the mutations are there, this is supposed that these will stimulate the JAK-STAT signaling, maybe JAK2 or some other mutations. Due to this increased signaling, there is more fibrosis within the bone marrow. It is believed that the characteristic marrow fibrosis is caused by the inappropriate release of fibrogenic factors from neoplastic megakaryocytes. Two factors synthesized by megakaryocytes have been implicated. One is platelet derived growth factor and second one TGF beta. Both these are non-fibroblast mitogens. So there is inappropriate excessive release of these factors which will result in increased fibrosis of the marrow. TGF beta also promotes collagen deposition, and this also causes angiogenesis. Marrow fibrosis leads to extramedullary hematopoiesis. So there is fibrosis within the bone marrow, erythropoiesis, myelopoiesis, megakaryocyte will be suppressed due to this excessive fibrosis. So this will result in the production of these hematopoietic elements in the other sites like spleen, liver, lymph nodes. This is extramedullary hematopoiesis. Red cell production at extramedullary sites is disorderly. So this disordered production may be in extramedullary site or even maybe within the bone marrow. This results in moderate to severe anemia. This means their lifespan is not normal, so these will be, many of these red cells will be destroyed earlier. So this will result in anemia in these patients. Now morphology, or we can say laboratory findings, what we will see in these patients. CBC, when routine blood examination, what we will see, the peripheral blood smear is markedly abnormal. In peripheral smear, we can see poikilocyte, variable shapes of the red cells. Most prominent are the teardrop cells. Teardrop cell. Many of the red cells are like teardrop. If we draw a shape of tear, so these cells are like this, teardrop cells. We can see nucleated erythroid precursors and erythroblasts. Nuclear erythrocytes are commonly seen along with immature white cells, and we can also see immature white cells. In both the immature cells of the erythroid series and the immature cells of white cell series, neutrophils. These are present on the peripheral blood smear. When both these are present in the peripheral smear, we call this a leukoerythroblastic picture or leukoerythroblastosis. This means the barrier between blood and bone marrow is loose. Erythroid precursors as well as myeloid precursors are coming in the peripheral blood. Giant platelets are also seen, so this means there is also abnormality in the production of platelets. Large size platelets, these are known as giant platelets. So we can see these large, almost approaching the size of a red cell. We can see this type of platelets on the peripheral smear in these patients. Bone marrow in advanced cases is hypocellular and diffusely fibrotic. When we try to aspirate the marrow in these patients, most of the time this is a dry tap. This means we cannot aspirate proper material from the bone marrow. In bone marrow aspiration. So we have to do bone marrow biopsy, trephine biopsy. So trephine biopsy, we cut a small piece and we stain it like histopathology, H&E staining. Then we can see the bone marrow elements at their own places. What we will see marrow megakaryocytes are present in clusters. So in these patients, this bone marrow biopsy, and this is more important, we will do H&E staining and also one special stain, reticulin stain, to see the fibrosis in the bone marrow. So both these we will do after trephine biopsy. So this is compulsory test for diagnosis of these patients. Clinically, we can see huge splenomegaly in these patients. Patient will complain of this. Marked splenomegaly with subcapsular infarct. The patients can tell us some history of repeated attacks of some severe pain. So these are due to attacks of infarction in the enlarged spleen. So huge splenomegaly with the history of subcapsular infarct. This is typical. So splenomegaly, this may be due to extramedullary hematopoiesis. Although extramedullary hematopoiesis is also going on in the lymph nodes, but these are not too much enlarged. So clinically, maybe these are not appreciable. Clinical features. Usually these are, this disease usually we will see in the older people, more than 60 years of age. The patients will present with progressive anemia and splenomegaly. Non-specific symptoms like fatigue, weight loss and night sweats are common. There is high turnover of the white cells. This will result in more production of pyrimidine. This will result in hyperuricemia and secondary gout. In any condition where there is high turnover of these cells, so these nuclear proteins, these are changed to uric acid, and patient can present with the symptoms of gout. In lab findings, what we will see, moderate to severe normocytic normochromic anemia. This may be accompanied by leukoerythroblastosis. We have already discussed immature precursors of thyroid series and immature precursors of myeloid. Both are present on the peripheral smear. We call this a picture of erythroblastosis. Sorry, this is known as leukoerythroblastic picture or leukoerythroblastosis. In routine CBC, TLC may be normal, low or high. In the earlier stages of the disease, usually this is high, very high, maybe more than 50,000 or 80,000 per microliter, like in CML or other types of leukemia. But in later stages of the disease, this will become low, and stage will come, then this may be below normal. So the patient can present with cytopenia. Cytopenia means hemoglobin will be low, RBC count will be low, TLC will be low, platelets may be low. This is usually in late stage of the disease. Platelet count normal or high but low in the late disease. So bone marrow biopsy is essential for a diagnosis. Bone marrow biopsy means trephine biopsy. This is compulsory for proper diagnosis. We will do HLE stain and also we will do reticulin stain, a special stain to see the fibrosis in the bone marrow. So, median survival is in the range of 4 to 5 years. In untreated patients, this is the median range. Maybe this is very difficult to treat these patients as compared to patients in CML or polycythemia vera. Threats to life include infection, thrombosis, and bleeding related to platelet abnormalities. So these are the more common causes of death. And transfusion to AML. A subset of these patients, maybe 5 to 20% of the cases, they can transform to more aggressive malignancy, that is acute myeloid leukemia. I have shown you this relationship in the lecture of polycythemia vera. How much percentage of these are going to change to AML or each other. Treatment. Nowadays, we can use these JAK2 inhibitors. We can target this excessive signaling and we can hope for a better, this will regress the spleen and we can hope for a more prolonged life in these patients. But the curative treatment, especially for young and fit patients, this is hematopoietic stem cell transplantation. Hematopoietic stem cell transplantation. This is answer to so many diseases, but this is a very complicated procedure. Mortality of the procedure is itself very high. So we have to weigh that only for needy patient we will advise for hematopoietic stem cell transplantation. Thank you. That's all for today.
after topic.